Hello, everyone. My name is Beth Pettis. I am a psychiatric mental health nurse practitioner, and today I will be presenting my quality improvement project titled Teaching Healthcare Providers About Physical Activity Counseling for Patients with Depression, a quality improvement project. The committee members for this project include my faculty chairperson, Dr. Lisa Stoyer, second reader is Dr. Maria Snell, and community member Dava Plumley. Depressive disorders are a worldwide healthcare problem with a lifetime prevalence range of about 10 to 20%. These types of disorders include major depressive disorder, minor depression, among others. These types of disorders are typically chronic in nature and will result in poor outcomes and increased mortality. Healthy People 2020 reported that in the United States, mental health disorders such as depressive disorders are one of the leading causes of disability among all illnesses. Physical activity is an evidence-based intervention for treating depression and depressive disorders, and implementing physical activity into the care of these patients has been shown by research to improve outcomes, and it can also act as a preventative mechanism in preventing depressive symptoms. Physical activity is cost effective and pretty widely available to most anyone with online programs, free classes on platforms like YouTube or Instagram. Even on Netflix now, there are free workout programs available. And healthcare providers are in a very unique position in recommending this evidence-based, cost-effective intervention to individuals with depressive disorders across all healthcare settings. While there is a lot of evidence supporting the mental benefits of physical activity, the problem is it is widely underutilized in practice as an intervention. And in fact, only about 7% of all illnesses in which healthcare providers recommend physical activity are for mental health disorders. This low rate could be due to a lack of knowledge and confidence in providing detailed guidelines of physical activity. And a recent study found that nurses typically do not recommend physical activity as an intervention if they have never received any formal training on the topic. And even more so, there is a lack of guidelines describing what constitutes adequate physical activity for this population, which can lead to inconsistency in recommendations of physical activity. The purpose of this project was to increase the knowledge and confidence of healthcare providers in recommending physical activity to patients with depressive disorders, and increase the frequency in which physical activity is being recommended to this population. The significance of this scholarly project to nursing practice is that nurses in all healthcare settings have been exposed to and care for individuals who suffer from depressive disorders. And so they are in a very unique position to be able to recognize any depressive symptoms and implement early intervention and protective measures for patients with depressive disorders. The significance in relation to advanced practice nursing is that advanced practice nurses are in a prime position in caring and creating treatment plans for patients with depressive disorders, and they are able to implement non-physical, non-pharmacological interventions such as physical activity into the patient's treatment plans. And they are trained in offering support and motivation to patients as they implement new healthy lifestyle and behavioral changes. And the significance to healthcare is that physical activity is really emerging as a standard of care in the treatment of depressive symptoms and is considered a valuable intervention. It is low cost, as I've already said, and it has been shown to promote increased quality of life. And as such, everyone in healthcare should be aware of the benefits and the importance of the inclusion of physical activity in practice. A thorough review of the current literature on this topic revealed three main themes. One was that treatment of adult depression with physical activity can result in significant reduction of depressive symptoms and can be preventative in the reoccurrence or the first occurrence of depressive symptoms or worsening depressive symptoms. The second theme was the factors influencing practice in relation to physical activity as an intervention. And multiple studies showed that healthcare providers reported a lack of knowledge on physical activity and what resources they had available that they could provide to patients. Other studies indicated that healthcare providers reported a lack of time, and also the healthcare provider's perception of the patient and how they thought they were, how likely they were to have a behavioral change would influence if they recommended it or not. The third theme was the healthcare provider education. And there is quite a lot of evidence that a focused educational training program increased healthcare providers' confidence and knowledge in providing physical activity counseling to patients with depression. And after the focused training, the healthcare providers observed barriers were less impactful, and there were sustained changes in practice following a focused educational training program. The theoretical framework this project was based on is Nola Pender's health promotion model. And the goal of this model is to promote healthy behaviors that improve and maintain wellness. This model is multidimensional, and it focuses on three main areas that influence an individual's health promoting behaviors. Specifically, these are individual characteristics and experiences such as prior related behavior, biological, sociocultural, and psychological influences. Also behavior-specific knowledge and affect, including interpersonal influences, perceived benefits and barriers of action, perceived efficacy and activity-related affect, and behavioral outcomes. The framework provides a structure that the scholarly project was implemented and developed and implemented, and it regards healthcare providers as part of the patient's influencing environment and therefore in a unique position to encourage adults with depression to implement physical activity into their lifestyle. And when doing so, the healthcare provider must consider the main influencing factors related to behavior change for each individual in order to provide effective patient-centered care. We'll now discuss the methods of this project. A quantitative exploratory design through a retrospective chart review was used, and the project was conducted at a clinic in the western region of the United States. It was an outpatient psychiatric clinic. The staff in the clinic were comprised of doctorate and master degree prepared psychiatric mental health nurse practitioners and students. The training clinic sees adult patients with a variety of mental health disorders, but including depressive disorders. The clinic averaged about 30 patients a day, just depending on the nurse practitioner student schedule. And the sample included the electronic health records from the clinic of adult patients with depression. The descriptive statistics of the data analysis and the sample included a sample size of 184. Of those, 68.5% were males and 31.5% were females. The mean average age was 42.1 years. The p-value was 0.001 and is less than the significant level of 0.05. The confidence interval suggested the true change in a ratio from pre to post intervention, and there was sufficient evidence to suggest a decrease in the ratio from pre to post intervention groups. There was a 2-proportion z-test that was used in the data analysis to evaluate if the ratio in which healthcare providers provided physical activity counseling to patients with depression increased post-educational intervention as compared to pre-educational intervention. And it was also used to evaluate the difference between patients who implemented a physical activity program into their daily routine post-counseling as compared to the patients who did not implement a physical activity program post-counseling. And the Z number result was 3.81. The instruments and procedures of the project were first to obtain the approval from the Internal Review Board or the IRB from Maryville University and from the organization that the clinic was under. After that was obtained, there was an educational program titled Providing Physical Activity Counseling to Patients with Depressive Disorders that was presented. That was in July of 2022. After the IRB approval was obtained, the data collection process began. And that included, as I said, a retrospective review of chart review that included adult patients who were seen at this clinic from April 5th, 2022 through September 2022. There were ethical considerations of this project, and the primary ones were the small possibility of a breach of confidentiality, protecting the participants' rights, and securing all of the data information. The intervention, as I mentioned in the last slide, was an educational program titled Providing Physical Activity Counseling to Patients with Depressive Disorders. That program included information on the current physical activity practice guidelines, and the education included how to document the physical activity counseling when it was applicable in the patient's electronic health record. The outcome did not show the outcomes of the intervention did not show a statistical significance, with the p-value of being less than a p-value of 0.001 being less than the significance level of 0.05. The pre-intervention sample showed that only 1.08% of patients in the sample received physical activity counseling, and then following the educational program, that increased to 17.39. All of the patients who received the physical activity counseling who came back for follow-up had all shown increases in their exercise levels. The facilitators of the project include the Nurse Practitioner Fellowship Director, who was at the training clinic, or the clinic the project took place, It included the staff and the students who worked there and saw patients. We also had support in the community with an exercise physiologist who helped give expert advice on physical activity guidelines and recommendations. And also, of course, the Maryville University faculty and staff chairperson were all very supportive and helped facilitate the success of this project. The barriers were an increased workload for the nurse practitioners, psych nurse practitioners, and students who were then asked to spend extra time providing physical activity counseling to patients with depression or depressive disorders. So to address this, a smart phrase was made and implemented to make the charting a lot faster, so it would take a little less time. And then for further incentive, the educational program included how to provide motivational interviewing for patients to implement the behavior change and how to document that therapy modality in order to get reimbursed for the therapy provided during the appointment. Strengths of this quality improvement program or project included a good sample size, which contributed to the strong power of the study. And it also had a cost-effective intervention of the educational program. The setting of the clinic was very supportive, and it was part of a larger academic center. So education and being up to date on evidence-based practices were very important to that clinic. The limitations included unforeseen timeline issues. One of those issues were the follow-up, post-intervention follow-up time frame occurred during a change in semesters for the students who attended the educational program. So some of the patients that were being followed by the students didn't come back for follow-up if the students didn't return for the fall semester. So I think that could have affected the post data information if we miss some of the patients who had received physical activity counseling and then didn't follow up since their providers weren't there. They probably, most of the time, if that happened, they got transferred to psychiatrist in a different part of the clinic. The results of the data analysis showed that the frequency in which physical activity counseling was provided to patients with depressive disorders at the clinic did increase from 1.08% pre-intervention or pre-educational program to 17.39 post-intervention. And all the patients who received the physical activity counseling showed an increase in their physical activity amount of minutes per week. However, this was not a statistically significant increase, which was not the expected outcome of this project. This was based on literature that showed an educational program did result in sustained changes in practice and increased frequency in which the physical activity was being provided to these patients. And to improve any outcomes in the future, considering the schedule of the students, and having a longer post-intervention timeline would be beneficial to allow more time for follow-up appointments and to make sure the timing coincides more with following the patients who are being seen by the students. The implications of the project to practice is that although the results were not significant, the results did provide sufficient information to show a true change from pre to post intervention, with changes noted in an increase in frequency in which physical activity counseling was provided. And along with these results, and because physical activity is an evidence-based intervention in the treatment of depressive disorders, The implication to practice is to continue providing patients with depressive disorders counseling on physical activity, and implementing an educational program on physical activity counseling into the standard of provider and patient education could ultimately improve the overall quality of care provided to patients with depressive disorders. Future research is indicated and should include populations beyond the clinic the project was implemented. And as the results showed that all the patients who received physical activity counseling increased their physical activity, future research should include if these patients had improved outcomes in relation to their depressive symptoms. Also, as the results showed that a non-statistically significant increase in frequency in which patients with depressive disorders were provided physical activity, there should be an evaluation if the healthcare providers who received that education had an increase in their knowledge and confidence related to the topic. The results of the data analysis of the study showed that educational intervention did not result in a statistically significant improvement in the frequency in which physical activity counseling was provided to patients with depressive disorders. As I discussed already, the study was faced with limitations that could have impacted the overall results, and future research is recommended. A plan for sustainability is the program, the educational program titled Providing Physical Activity Counseling to Patients with Depressive Disorders was recorded, and that recording was given to the director of the nurse practitioner training program at the clinic. This is so that any new students or staff coming into the clinic can receive the education. In addition, copies of the PowerPoint slides from the educational program were provided to the clinic manager and all of the healthcare providers who attended the educational intervention. That concludes the presentation of my quality improvement project. Please feel free to ask me any questions, and I hope you enjoyed learning about physical activity as an intervention in treating patients with depressive disorders, and about an educational program to educate healthcare providers on how to provide that physical activity counseling. Thank you. The next few slides will be of my references used in this project.